I've been a gastroenterologist for over 20 years. I've scoped thousands of stomachs, read thousands of biopsies, sat across from thousands of patients and delivered news that changed their lives. And in all that time, I have never seen a single medication cause as much quiet, invisible damage as the one I'm about to describe. Her name was Helen, 71 years old. Retired school teacher. Sharp, independent. Still drove herself to the grocery store, still worked her garden every Saturday. By any measure, she was fine. Then her doctor prescribed a small white pill for acid reflux. Safe, he said. One of the most commonly prescribed medications in the country. That part was true. What nobody told Helen, what nobody tells the tens of millions of Americans swallowing this pill every morning, is what happens when the weeks turn into months and the months turn into years. 18 months in, no appetite, bloating, low-grade nausea that never left. Fatigue she kept blaming on age. When her tests came back, her gastroenterologist went cold. The lining of her stomach, the protective barrier between your digestive acids and living tissue, had been eroding, slowly, silently for months. And the medication prescribed to protect her from acid was the same one tearing down the wall her body depended on to contain it. I didn't read this in a study. I saw it on a monitor in an endoscopy suite, looking at tissue that had no business looking that way. Helen is not a rare case. She is one of millions. I'm Dr. Savannah Blaire, board-certified gastroenterologist. This channel exists for one reason: to tell adults over 60 what 2 decades of practice and published research have shown me. In plain language, without the filter of a 15-minute appointment and prescription pad. That pill belongs to a class of drugs called proton pump inhibitors, PPIs. Prilosec, Nexium, Prevacid, Omeprazole, the third most prescribed drug class in the United States. And I'm telling you today, the risks they carry after 60 are nothing like what's on that label. Today, 5 ways this daily pill is silently eroding more than your stomach lining, your kidneys, your bones, your brain, your heart. 5 systems, 1 pill. A pattern the medical literature has documented for over a decade that most patients are never shown. Stay through all 5. Number 3 stops people cold every time I walk them through it. And number 5, the one that connects everything, the one that has ended lives that didn't need to end, is the reason I made this video. My name is Dr. Savannah Blaire. This channel does one thing: helps adults over 60 understand what the research actually says about their health. Plain language. No rushed appointments. No pharmaceutical sales brochures. What I'm about to share doesn't come from a textbook. It comes from years inside the published medical literature. Gastroenterology journals, pharmacology reviews, long-term population studies. Watching what happens when a medication built for short-term use quietly becomes a permanent fixture in someone's daily routine. Here's the truth most doctors won't say in a 15-minute appointment. Proton pump inhibitors were designed for 8 to 12 weeks. That was the clinical intention. That was what the trials were built around. But somewhere between the prescription pad and the pharmacy counter, that window disappeared. Today, tens of millions of Americans over 60 take these pills every single morning, indefinitely, with no end date, no reevaluation, and no warning about what chronic use is doing to their bodies. The stomach lining is just where the story starts. After 60, one of the most commonly prescribed medications in America, a pill millions take every morning without a second thought, may be causing more long-term harm than the condition it was prescribed to treat. Not because your doctor made a mistake, not because pharmaceutical companies are villains, but because proton pump inhibitors were built for a short-term problem. And the body after 60 is not equipped to absorb the consequences of taking them forever. The risk-to-benefit math changes dramatically with age and duration. Almost nobody is doing that math with you in the room. 5 systems, 1 pill, a pattern documented in the medical literature for over a decade that most patients are never shown. Stay through all 5, because number 3 is the connection most never see coming. And number 5 is why this conversation is more urgent than almost anything else I could put in front of you today. Before the 5, you need one concept. Without it, nothing I'm about to show you will fully land. I call it the acid dependency trap. Most people believe stomach acid is the enemy, the thing causing the burning, the reflux, the discomfort. So when a pill comes along that shuts it down, less acid, less pain, it feels like the obvious solution. Here's what changes after 60. 3 things. First, stomach acid is not optional. It is not a design flaw. It is the engine of your entire digestive system. It breaks down protein. It kills harmful bacteria before they reach your intestines. And it is how your body extracts B12, magnesium, calcium, and iron from the food you eat. Shut the acid down and you don't just stop the burning. You stop the absorption. A body over 60 that can't absorb what it needs begins breaking down from the inside, slowly and visibly over months and years. Second, PPIs don't treat the root cause of reflux. They suppress a symptom, the weakened esophageal valve, the excess abdominal pressure, the dietary triggers. None of that is touched by the pill. So the moment you stop taking it, acid surges back, often worse than before. Doctors call it rebound hyperacidity. Patients call it proof they need the medication forever. It's not. It's a withdrawal effect that has been mistaken for a chronic disease. Third, the longer you take a PPI, the harder it becomes to stop. And the harder it becomes to stop, the longer the damage compounds, quietly, in organs you cannot feel until it's already significant. That is the acid dependency trap. Keep it in your mind, because you will see it operating at every single level of what follows. Before we get into the 5, I want to take 1 second. If you're watching this right now, there's a real chance you're on a proton pump inhibitor yourself, or someone you love is. Maybe you've been on one for years. Maybe you were handed a prescription and never told it had an end date. Maybe you've been asking questions your doctor hasn't had time to answer. Whatever brought you here, drop your name and the city or country you're watching from in the comments right now. I read every single one. I want to know who's in this community, what you're dealing with, and what questions you're carrying into this video. Item 1. Your stomach lining. His name was Robert, retired civil engineer. Methodical man, kept a medication log in a small notebook on his nightstand. He'd been on Omeprazole every morning for 6 years. Originally prescribed for esophagitis that cleared up within 3 months. Nobody ever suggested to stop. The prescription kept renewing. Robert kept taking it. By year 5, weight loss without trying. Appetite gone so gradually he barely noticed. Then a dull, persistent ache just below his ribs. Not reflux, something different. His gastroenterologist ordered an endoscopy. Atrophic gastritis. The stomach lining thinned and deteriorated. Acid-producing cells worn down, protective barrier compromised. His stomach's ability to function as a digestive organ, fundamentally impaired. Here's the mechanism. Your stomach lining is not passive tissue. It's a dynamic barrier that depends on a precise chemical environment to maintain itself. When PPIs suppress acid long-term, that environment shifts. A protein called gastrin surges, the body's attempt to compensate. Chronically elevated gastrin overstimulates the cells lining the stomach wall. The result, gastric mucosal atrophy, the same finding on Robert's endoscopy. A study in the journal Gut tracked over 24,000 long-term PPI users. Duration of use correlated directly with severity of gastric mucosal damage. Longer use, thinner lining, higher risk of ulceration, bleeding, and in the most serious cases, cellular changes gastroenterologists do not take lightly. What to do? Ask your doctor one direct question. Am I still taking this for the original condition, or am I taking it to prevent withdrawal rebound? That distinction changes everything. For many patients, a supervised taper combined with dietary changes, smaller meals, no late eating, removing trigger foods, resolve symptoms without a pill. H2 blockers like famotidine, used occasionally rather than daily, carry significantly less long-term mucosal risk for patients who need some support during the transition. Item 2. Your kidneys. Her name was Carol, 67 years old, former nurse from suburban Chicago. She knew her medications. Read this inserts. Not the kind of patient who missed warning signs. But kidney damage has no warning signs. Her annual blood work flagged it first, a slow, creeping rise in creatinine levels over 3 consecutive years. Her doctor attributed it to normal age-related decline. It was only when her nephrologist connected the timeline, 4 years on a PPI, 4 years of rising creatinine, that the conversation changed. Chronic interstitial nephritis. Inflammation of the kidney tissue itself, not from infection, not from blood pressure, not from diabetes. From her daily acid pill. A study in JAMA Internal Medicine followed over 10,000 adults and found long-term PPI users had a 20 to 50% higher risk of chronic kidney disease. A separate analysis in the Clinical Journal of the American Society of Nephrology examined over 125,000 patients. PPI users were 96% more likely to develop kidney failure over 5 years than those on H2 blockers. 2 mechanisms. First, direct immune-mediated inflammation of kidney tubules triggered by the drug. Second, magnesium depletion. PPIs impair magnesium absorption. And magnesium regulates the tiny vessels that filter blood through your kidneys. Chronically low magnesium means chronically stressed filtration. Over years, that stress accumulates. The insidious part, kidney damage rarely hurts. No organ sustains more damage in complete silence. By the time symptoms appear, function is already significantly reduced. What to do? If you've been on a PPI for more than 1 year, ask your doctor for a comprehensive metabolic panel and a magnesium level. Standard blood tests. They cost almost nothing. And the information could change the trajectory of your next 5 years. Item 3. Your brain. This is the one that stops people. His name was Dennis, 72 years old, retired high school principal. His wife came to his neurologist after noticing what she described as a slow dimming. Not dramatic memory loss, just a gradual fading. Forgotten appointments, lost mid-sentence, questions repeated 20 minutes apart. His neurologist suspected early cognitive decline. His family braced for Alzheimer's. What his geriatric pharmacist found instead? A B12 level so critically low it registered at the very bottom edge of detectable. Dennis had been on Omeprazole for 7 years. Here's the science every person over 60 on a PPI deserves to hear. Vitamin B12 requires stomach acid to be released from food, a process called proteolytic cleavage. Without adequate acid, B12 passes through your digestive system largely unextracted. And B12 deficiency doesn't just cause fatigue, it causes neurological damage. It strips the protective coating from the cables your brain uses to transmit signals. The cognitive symptoms it produces mirror early Alzheimer's so precisely that the two are routinely confused, even by experienced neurologists. A JAMA study examining over 25,000 patients found long-term PPI users had a 65% higher risk of B12 deficiency. A separate JAMA neurology analysis of over 73,000 adults 75 and older found PPI users had a 44% higher risk of developing dementia. But here's what makes Dennis's story matter beyond the statistics. When his B12 was restored through injections, bypassing the digestive absorption problem entirely, and his PPIs was carefully tapered, his wife described watching him come back. The words returned. The sharpness returned. The man she had been quietly grieving, while he was still sitting across from her at the dinner table, returned. Drug-induced cognitive decline is often reversible. That is one of the most important senses in this entire video. What to do? If you've been on a PPI for more than 6 months, ask your doctor to test your B12 level. If it's below 400 picograms per milliliter, even if your lab marks it as within normal range, that level in an adult over 60 is worth a serious conversation. B12 injections bypass the absorption problem entirely and are available at virtually any primary care practice. Item 4. Your bone. Her name was Patricia, 69 years old, walked 3 miles every morning, no family history of osteoporosis, no smoking. Decent diet, doing everything right. Then she slipped on a wet kitchen floor, barely even a stumble, and fractured her hip. Her bone density scan told a story that didn't match her lifestyle at all. Severe thinning well beyond what her age and activity level should have produced. Patricia had been on pantoprazole for 8 years. Here's the mechanism. Calcium absorption requires an acidic stomach environment to dissolve and be taken up by the intestinal lining. Suppress acid chronically and calcium passes through largely unused. Your body, sensing the shortfall, does exactly what it's designed to do. It pulls calcium from the most available reservoir it has, your bones. The FDA issued a formal safety communication on this specific risk. Studies found patients on long-term PPI therapy had a 10 to 40% increased risk of hip, wrist, and spine fractures. A British medical journal study tracking over 40 patients found fracture risk increased in direct proportion to duration of use. Longer exposure, greater bone loss. In a woman like Patricia, already navigating the natural bone density loss after menopause, years of impaired calcium absorption isn't a minor variable. It's the difference between a stumble and a hip replacement. What to do? Ask your doctor for a DEXA bone density scan if you've been on a PPI for more than 2 years. Ask whether your calcium and vitamin D levels have been tested. And ask the question most patients never raise. Is my fracture risk being factored into the decision to keep me on this long term? Item 5. Your heart. This is the one that connects everything. This is why I made this video. His name was George, 76 years old. Retired firefighter. Not someone who complained easily or visited doctors unless he had to. 4 years earlier, he'd had a cardiac stent. His cardiologist prescribed clopidogrel, a blood thinner, standard protocol, done correctly. George was supposed to be protected. What his cardiologist didn't know, George's gastroenterologist had placed him on omeprazole at the same time. Also standard practice, to protect the stomach lining from blood thinner irritation. 2 specialists, 2 correct decisions made in isolation. 1 interaction neither of them flagged. Here's what the research has documented. Certain PPIs, omeprazole and esomeprazole specifically, inhibit a liver enzyme called C2S19. That enzyme activates clopidogrel in the body. Block the enzyme, and the blood thinner stops thinning. In a patient with a cardiac stent whose entire protection against clot formation depends on that drug working, the consequences can be catastrophic. A study in the Journal of the American College of Cardiology found patients on both clopidogrel and PPIs had a 50% higher rate of major adverse cardiac events compared to patients on clopidogrel alone. The FDA issued a specific drug interaction warning, and yet, this combination remains one of the most commonly written pairings in cardiology practices across the country today. George had a second cardiac event 14 months after his stent. His cardiologist identified the interaction afterward. Switching him to pantoprazole, a PPI with significantly less CYP2C19 interference, came too late. It does not have to come too late for you. What to do right now? If you're taking clopidogrel, sold as Plavix, and any proton pump inhibitor, simultaneously bring both bottles to your next appointment. Ask your cardiologist directly, is this combination safe for me? And is there a PPI with less interaction risk I should be on instead? That single question, asked before an event rather than after, is the entire point of this video. I promised you something you could actually use. Here it is. 5 questions. Every time you or someone you love is on a PPI, or being considered for one, have these ready. Write them down. Put them in your phone. Bring them to every appointment. Question 1. Was this medication prescribed for a short-term condition? And has that condition been reassessed? PPIs were designed for 8 to 12 weeks. If you've been on one for a year, 2 years, 5 years, with no conversation about stopping, that silence is not medical confirmation you still need it. It's a gap in the review process you have every right to close. A good physician will welcome this question. It gives them an opening the appointment schedule rarely makes room for evaluation. Question 2. Has my B12, magnesium, calcium, and kidney function been tested recently? These are the 4 systems most directly damaged by long-term PPI use, all testable with standard blood work, all actionable if caught early, and in most cases, never checked in the context of PPI use because nobody explained the connection. You're now the person in the room who knows to ask. Question 3. Am I on any medication that interacts with this PPI, particularly clopidogrel, methotrexate, or certain antifungals? Drug interactions involving PPIs are documented and routinely missed when multiple specialists are writing prescriptions independently. Your pharmacist can run an interaction check in under 2 minutes. Ask them. That 2-minute conversation has prevented strokes. It has prevented cardiac events. It costs nothing. Question 4. What would a supervised taper look like for someone with my history? This does 2 things. It signals you're not demanding to stop cold turkey, which can cause dangerous rebound hyperacidity. And it opens the door to a structured, medically guided reduction plan that millions of patients have completed successfully. Rebound hyperacidity typically peaks within 2 weeks and resolves in 4 to 6 weeks when the taper is done correctly. Knowing that timeline in advance transforms a frightening withdrawal into a manageable process. Question 5. What is the most effective non-pharmaceutical intervention for my specific reflux trigger? Because the research is consistent. For the majority of adults over 60 whose reflux is driven by a weakened esophageal sphincter, elevated abdominal pressure, or dietary pattern, lifestyle interventions produce comparable superior long-term outcomes to daily PT use. Elevating the head of the bed 6 inches, no eating within 3 hours of sleep, smaller evening meals. Identifying and removing personal trigger foods. These are not consolation prizes. Study after study shows they address the underlying mechanism, not just the symptom. Any physician who takes your health seriously will welcome every one of these questions. They will respect you more for asking. And if your doctor makes you feel difficult for raising them, that's not a reflection of your unreasonableness. That's information about whether that appointment room is the right place to be making decisions about your long-term health. I want to close with something that goes beyond proton pump inhibitors, beyond any single medication. Because what I've really been describing today is a pattern. And the pattern matters more than any one pill. There is a difference between medicine that manages a symptom and medicine that serves your life. After 60, the goal of your healthcare should not be to keep a prescription active. It should be to protect the years ahead, your independence, your mental clarity, your ability to wake up and feel like yourself. The best physicians I've encountered understand something the system rarely rewards them for saying out loud. Sometimes the most sophisticated clinical decision is not adding something. It's carefully, thoughtfully, taking something away. Deprescribing, the intentional supervised reduction of medications no longer serving their original purpose, is one of the fastest growing fields in geriatric medicine. Not because doctors are admitting failure, because the evidence is demanding a reckoning with what decades of low scrutiny prescribing has cost millions of patients. Helen, the retired school teacher whose story opened this video, didn't need a more aggressive treatment plan. She needed someone to look at what was already in her medicine cabinet and ask a question nobody had asked in years. Is this still right for her? Is this still serving her? You have the right to ask that question about every medication you take. You have the right to know what a drug was designed to do, how long it was designed to be used, and what the evidence says about taking it beyond that window. You have the right to a healthcare experience that treats you as a whole person, not a collection of isolated symptoms each assigned their own prescription. A complete human being whose kidneys, bones, brain, and heart are all connected, all affected by the same daily pill, all worth protecting with the same urgency. The stomach lining is where this story started, but what I hope you carry out of this video is something larger. A new relationship with the medications you've been trusting without question. Trust in medicine, as in everything else, should never be unconditional. It should be informed, revisited, and always working in your favor. You are not a passive recipient of whatever fills a prescription bottle. You are an active participant in your own health. And that informed, direct, unafraid to ask hard questions, is more powerful than anything you'll find in that bottle. More powerful than any pill. If this video gave you a new way to think about a medication you've been taking without a second thought, please subscribe. Every week I make videos like this one, practical, evidence-based, honest, built specifically for adults over 60, who deserve more than a rushed appointment and a renewed prescription. This is the conversation your doctor wishes the system gave them time to have with you. Hit subscribe. Don't miss the next one. Before you go, I want to hear from you. Have you or someone you love been on a proton pump inhibitor long-term and never once been told it had an end date? Have you noticed changes in your energy, your memory, your bones, your digestion, and never connected them to the pill you take every single morning? Leave that story in the comments. Because the person who most needs to hear what you experienced is probably not searching for this on their own. They're taking their pill every morning the same way they have for years, trusting that silence means safety. Your comment might be the reason they finally asked their doctor a question they've never asked before. That's not a small thing. That's the whole point. Take care of yourselves. Stay curious about what goes into your body. See you in the next one.